treatments in a human rights perspective. This side event is promoted by Forum Droge, co-promoted by the International Drug Policy Consortium, Harm Reduction International, Eurompud, which is the network of people who use drugs, Luca Coscioni and the Società della Ragione, that are two Italian NGO. In this event, we will discuss about the right to health of people who use drug and the right to choose treatment in a free way, in a human right perspective. I give the floor first to Adria Cos Fernandez from the IDPC, and he will help us to create the framework of the right to health in a human right perspective. Adria.
Thank you very much, Susanna, and thank you to Forum Droge for the invitation. I think it's a very timely, very interesting side event. Thank you to the people who have joined us in person or online. It's not a lot of us, but as we say in Catalan, in the little jar, we have the good jam. And that definitely is the case for today's event. I will speak very briefly about what is harm reduction from a human rights perspective. How does it fit into international law and international standards? And lastly, I will mention a couple of processes that are going on that will strengthen our understanding of harm reduction within the international human rights framework and the right to health in particular. I wanted to start with a bit of a reflection on what is harm reduction of the definition. We don't see very well in the slides, Leo. Can we make it a bit bigger? Because we can't really read it. Yeah, this one. Oh no. Oh, I can't tell you what's in the slides anyways, but I wanted to start by comparing two definitions of harm reduction. The first one is the historical, that's great. The historical definition of harm reduction, which is in the context of UN documents, harm reduction is normally defined as through a very technocratic and a very medicalized way. Defining it as a series of interventions to reduce the health harms associated to drug use without aiming to reduce drug use itself. It's grounded on the practices to stop the spread of the HIV epidemic and other bloodborne diseases, as well as to reverse overdose epidemics. I put here the definition of the WHO 2016 guidelines. In here, as you can see, harm reduction is defined as a comprehensive package of interventions. So it's not even a concept in itself, but just a list of interventions, of medical interventions. And traditionally, these interventions have been grounded on the situation that we have faced in Western Europe and Eastern Europe and Central Asia and North America of injecting drug use. So this concept has been built historically, and the evidence we have is mostly built around injecting drug use and not other forms of drug use. And that is the definition of harm reduction that we will normally refer to and WHO, changing now from UNAIDS, but it's a kind of technocratic medicalized stuff that we have seen historically. I haven't changed yet the slides. No. We have another definition of harm reduction. Oh, I can control the slides. That's great. That is great. We have another definition of harm reduction, which is, I put here the example of the one prepared by Harm Reduction International, which is harm reduction referring to policies and programs and practices that tend to minimize the negative health, social, and legal impacts associated with drug use, but also with drug policies and drug laws. So it's a broader definition, and we couldn't even go further and move away from a medicalized term to think of harm reduction as providing housing, food, providing an adequate standard of living, providing everything that the person needs to live a life lived with dignity. So that second definition, I think, that fits very well with the human rights framework for tourism. The first one is because it recognizes that rights are interdependent, that we can't have, we're not addressing what we need to address just with one intervention on its own. And secondly, because it's about recognizing everyone's equal value and dignity, and that everyone should live their life in their own terms. And in that regard, it's not only to meet people where they are, in order to take them into a medical process, but to meet them where they are, be with them, and let them create their own solutions together with them. So it has that philosophy. Harm harm reduction under the international law has been explored and under the right to health. Okay. Has normally explored under the right to health under Article 12 of the International Convention of Economic, Social, and Cultural Rights. But I would say that if we take this broader definition of harm reduction, it could even go beyond the right to health itself. And you have Article 11 that recognizes the right to an adequate standard of living, which comprises again housing, food, etc. So we could see harm reduction as a series of practices that go well beyond just the strict framework of the right to health into something broader and richer than that. And when we begin to develop more human rights work from a harm reduction perspective, we should start exploring these other branches and dimensions of harm reduction itself. I think that by now there is a total consensus on human rights bodies that harm reduction is at the center of the right to health for people who use drugs, together, of course, with other interventions, but at the center of it, and strongly so. People refer very often to this great statement by the UN Special Rapporteur on the Right to Health from 2020 in response to the COVID-19 pandemic, where he said that harm reduction interventions are essential for the protection of the right to health of people who use drugs. And that's the formulation that we will see emerge in discussions normally. Like in Geneva right now, where there's a discussion at the Human Rights Council on drug policy and human rights. And many member states have come up citing this statement and using that formulation. It's essential to the right to health, to the protection of the right to health of people who use drugs, or it's central to the right to health of people who use drugs.
You have to wait some second. Because...
you have to wait. Yeah, thank you, Leo. Beyond that statement, of course, the UN treaty bodies, which are the bodies that are charged with monitoring and interpreting the international human rights law conventions, have recognized the value of harm reduction in many occasions. The central one is the UN Committee on Economic, Social, and Cultural Rights, because it interprets the International Covenant on Economic, Social, and Cultural Rights. And it has now for long included always questions about harm reduction in country reviews as well as recommendations. And there is by now, in the last 5 years, over 15 recommendations with formulations such as the committee recommends that the state party pursues its efforts to secure sustainable funding for HIV prevention activities and harm reduction for Bulgaria. The committee expresses its concern about the persistence of a predominantly punitive approach to drug use, the lack of harm reduction programs for drug users, and the absence of legislation in that regard from Bolivia. Moving beyond we're still in the prior one. Beyond the Committee on Economic, Social, and Cultural Rights, many other treaty bodies have also provided recommendations on harm reduction. So the Committee on the Rights of the Child, which monitors interpretation of the Convention on the Rights of the Child, has many times. Well, as you know, Article 33 of the Convention on the Rights of the Child is the only one in the whole human rights framework that refers to drugs. It's a right in a very stigmatizing and old-fashioned and dated formulations to be free from drug use. But of course, the committee has interpreted that article in much broader terms to say that states have the obligation to provide youth-friendly treatment and harm reduction, and as well as other interventions for children. So harm reduction has been recommended over 35 times by the Committee on the Rights of the Child under Article 33. But we have also recommendations from CEDAW, Committee on the Elimination of Discrimination Against Women, Human Rights Committee, and the Committee Against Torture. So we see that harm reduction goes again beyond strict right to health perspective. It intersects with discrimination against women, situation of children and other vulnerable populations, torture. In the case of Committee Against Torture, it's about denying opioid substitution treatment in places of detention, etc. The Working Group on Arbitrary Detention has also had a similar finding that if somebody is detained without access to opioid substitution treatment and suffer withdrawal symptoms, there might be ill treatment or torture connected to that. So it's really a central element across the human rights system. If we go beyond, and now we can change, the human rights system itself, I mean, by now the support for harm reduction, at UN level is overwhelming. Technical agencies have recommended it for years now, WHO, UNAIDS, OHCHR, UNODC itself also has recommended it, not that much using these words in public because there's some political dynamics around it, but definitely from a technical point of view, there's lots of recommendations connected to the mostly the old school, like the injecting paradigm of harm reduction. But still it's there. And of course, the UN position on drugs from 2018, which really brings together all UN agencies in the drug policy framework, and it has a strong endorsement of harm reduction as well as other interventions, of course. And then we have the political documents by member states themselves. Now, in Vienna at CND, we have never had a resolution with the words harm reduction. Just hasn't happened. It's a disputed document, but we are starting to see harm reduction emerge in political documents, and it's going to happen. I'm pretty sure at some point that it's going to also fall in Vienna. We have a 2021 political declaration on HIV and AIDS adopted at the General Assembly with 162 votes in favor, so overwhelming majority, which has support for harm reduction. We have the 2021 Human Rights Council resolution on HIV and AIDS, which also has harm reduction. And lastly, we are now seeing the debates on resolution on human rights in drug policy in Geneva, and so far, harm reduction is sitting within that resolution. And I will come to that in a second. Change. So I just wanted to think also very quickly about what does it mean to include harm reduction within human rights framework when it comes to obligations of member states. So when we look to human rights law, we normally think about state obligations in in three categories: obligations to respect human rights, obligations to protect human rights, and obligations to fulfill human rights. So obligation to respect the right to health, for instance, with regards to harm reduction, means obligations to not interfere and not intervene actively by state actors. So that include things like obligation to not criminalize harm reduction, which is something that happens in many countries, to not harass harm reduction services, which happens in many countries, placing police in front of a harm reduction center, etc. But also obligations to not impose undue burdens or licensing or registering on harm reduction sites, because this could be be seen as arbitrary. Obligation to protect means make sure that private actors, such as sometimes religious groups, political activists, don't interfere with harm reduction services to protect harm reduction services in the community. And of course, obligation to fulfill, which would be the critical one also, which is of course to invest in harm reduction services, to ensure that the broad range of them are available, etc. So we really should think as states having these duties from a human rights perspective. And I'm about to finish. Yep. Sorry. Okay. I just wanted to finish by mentioning that there is now an ongoing process that will, I think, help us explore more what it means, what the right to health and other rights mean, which is the Committee on Economic, Social and Cultural Rights, which interprets the International Convention on Economic, Social and Cultural Rights. Somebody is having their own interpretation about
what is that?
Human rights. That is, yeah.
Okay.
Yeah, Leo, what's going on there? Yeah, the committee is now starting the process to have a general comment on economic, social, and cultural rights and drug policy, which means that it will provide an interpretation of what economic, social, and cultural rights mean with regards to drug policy. And it's going to be like an authoritative interpretations we all member states will have to look at. And it's an opportunity for us to engage with the committee, and there will be a process that will be published soon to include all the elements that have to be reflected there. So let's engage with it and let's strengthen that connection. And I'm sorry if I went too long.
Okay, thank you, Adria. And we see that things are going on in the perspective of human rights and drug policy. And now we have a pre-record intervention that is interesting, I think, for all of us, is an intervention by Elina Steinert. She is a human rights expert and a former member of the working group on arbitrary detention. And she will talk about the intersection of arbitrary detention and the right to health.
First of all, I thank the organisers of this special event for inviting me as a former member and chair rapporteur of the United Nations Working Group on Arbitrary Detention. As I'm sure the learned audience is well aware of, in July 2021, the working group concluded and presented to the Human Rights Council its study on arbitrary detention and drug policies. This is a significant piece of work that was undertaken by the working group at the request of the Human Rights Council. This request, dating back to 2019, was a tangible acknowledgement by the Council of the work of the working group on issues concerning the negative impact of the drug policies upon the right to personal liberty over the 3 decades of the working group's mandate. This includes increasing and, in some cases, systematic instances of arbitrary deprivation of liberty as a consequence of drug control laws and policies.
Bad poor health outcomes for the access of hazardous drugs, and we're also trying to
about the frequent use of various forms of administrative detention imposed to control people who use drugs, often framed as health intervention, which may lead to involuntary commitment or compulsory drug treatment, in turn leading to arbitrary deprivation of liberty. Through this study, the working group sought to provide further guidance to states and other stakeholders on practical measures to prohibit and indeed prevent arbitrary arrest and detention in the context of drug policy. Because let us not forget, the prohibition of arbitrary deprivation of liberty is absolute. There are no reasons that can justify it. There are no circumstances that can legitimize it. For our discussion today, I would like to specifically focus on the very important intersection of the right to health and the right to personal liberty, more specifically, the freedom from arbitrary deprivation of liberty in this context. This is crucial because one must always recall that deprivation of liberty is not a concept arising exclusively in the criminal justice context. Individuals can and indeed are deprived of their liberty in a wide variety of different contexts, including healthcare. What the working group established through its study, that despite the evidence in terms of the lack of effectiveness of compulsory treatment, the practice of confining people who use or who are suspected of using drugs against their will in state-run or in private compulsory drug treatment centers is still widespread and can and does give rise to arbitrary deprivation of liberty. Therefore, the working group clearly states that the drug treatment must lie solely in the hands of specifically trained health professionals, and the working group underscores the importance of making drug treatment voluntary based on informed consent, and therefore recommends prompt closing of all compulsory drug detention centres and making available voluntary, evidence-informed and rights-based health and social services in the community. Let me conclude by recalling the conviction of the working group of the need for a shift from punitive to supportive approach, which should be translated into making drug treatment voluntary and based on informed consent. I thank you for your kind attention and wish you an engaging event.
So I think that this contribution is interesting, and I remind that the working group on arbitrary detection gives a very important contribution to the discourse of human rights for people who use drugs. Now I'm going to change my role from coordinator to speaker, because I want to say something just on mandatory treatments, but in a particular sense, because I want to highlight some aspects regarding the alternative measure to coercive sanction that deals with the freedom of choice of people who use drugs and with their right to health. Leonardo, you okay? The next one, thank you. We know that alternative sanctions are very important to mitigate the impact of criminalization and of incarceration for drug crimes, first of all for minor drug crimes. But in the current system of alternative sanction, I refer here to the European context, but I think that the same thing could regard also other national context. In the current system of alternative sanction, there are a high risk of violation of some fundamental rights. You see there are two statements from the working group on arbitrary detection. And in the 2021, they say that the threat of imprisonment should not become a coercive tool to incentivize people into drug treatment. And they added that if this happens, this is an acceptable infringement on the right to choose one treatment freely, to refuse a treatment, or to discontinue it in any time. So I think we have considered the risk of a de facto mandatory system in mandatory treatment in this specific context. The next one, I want to mention three aspects of this risk. The first is deals with which kind of treatments are usually accepted by the court. I think that we have a problem of cultural approach of the judge, because they are always abstinence oriented, and they are not used to consider the wide range of possible treatments in alternative to prison. For instance, it's very difficult to have a treatment harm reduction oriented, or to include the goals not of abstinence, but the goals of a stabilized situation of the controlled use of drug. It's often very difficult also to see that the OST can be a possible alternative treatment. So the risk is that people are forced, I put this title, sentences to abstinence, are forced to choose this kind of treatment, even if they would make another kind of choice. I don't repeat what Adria has already said about harm reduction, that is recognized as a basis of the right to health of people of use drug. The next, the second aspect I want to stress is that the court usually consider a relapse or a new period of drug use as a sort of a criminal recidivism, and a reason to stop the treatment and to send people in prison again. And this is clearly in conflict with what all of us know, and what health professional knows, and what people who us know, that relapse is simply a step in a treatment process. And of course, that abstinence is not the only goal. The working group on arbitrary detention is very clear on that. And he stated that the supervision of the treatment process would be made by health professional, not by the court. But we know that this is very difficult, and we know that very often there is conflict between health professional who take care of people and the court. Because the court power is stronger than the health professional power. So people really risk to stop their alternative measures just because they have their own story during the treatment process. And the next, the third factor that I want to stress is deal with the question treatment for whom, because sometimes we have an individual situation where people don't need treatment at all. If we think of that context where use, possession, or cultivation for individual personal use is criminalized, we can have a lot of people who are sanctioned, who look for alternatives, but who don't need treatment at all because they are not problematic. But sometimes they are forced to choose a treatment just to avoid prisons. But this is really a paradox. And one great big problem in this sense is that people who use drug have a lot of difficulties in assessing to all other kind of alternative measures. Because if you are a drug user, okay, it's obvious that your alternative is treatment. And it's very, very difficult to have access to all the other measures that it would be formally accessible. And you see that here a quotation for a study that we make in 8 member states for the Civil Society Forum on Drugs, and where the people we interview just stress this difficulty in assessing to other kinds of measures. So to conclude, the next one, Leo, grazie. To conclude, but in an optimistic way, because I think that these 3 difficulties could become 3 opportunities for action for us. So the first is let's try to work also with the judge and try to change their attitude and to open the range of possible option for treatments as an alternative, included harm reduction. And also we could work to balance the power of judge and the powers of health professional. And also we would help people who use drug to improve their power in this kind of negotiation. The second action we could do is a fight, because all the kind of alternative measure could be accessible by people who use drug. And last but not least, of course, you would fight for decriminalization of the minor drugs crime to avoid prison for people who use drugs. So thank you. I come to my previous role of coordinator of the panel and give the floor to Ligia. Ligia Parodi is a member of Euroinput and Input too, that are the networks of people who use drug.
Thank you, Susanna. Good morning, all. My name is Ligia Parodi. I come from Portugal. I'm a cisgender woman. I'm a mother, a drug user, and a harm reductionist. Harm reduction has long been practiced and developed among drug users. I bring you 3 examples of actions developed by our communities. The first one is from the grassroots periods. In the 80s. In 1981, in Rotterdam, Netherlands, there was a group called Junkie Bond. They inspired creation of many other groups. As early as 1981, Junkie Bond started an underground needle and syringe program with the aim of protecting people who inject drugs from hepatitis B. They took an activist approach, campaigning for effective services for drug users, challenging discrimination and defending human rights. You all know what else emerged in the 80s. Human immunodeficiency virus was identified in 1985, having already made many victims. Needle sharing soon started to be identified as one of the main causes for the rapid spread of HIV among injecting drug users. In 1985, when the first drug user in the Netherlands was diagnosed with AIDS, Rotterdam had an estimated 3,000 regular heroin users, of whom about 30% injected drugs. In '86, the first HIV study among Rotterdam drug users found 12% of HIV positive. This rate never got any higher. In Amsterdam, 1 hour away from Rotterdam, HIV prevalence among injecting drug users was already 30% in '86, a figure which gradually declined in the second half of the '90s. This context was relatively supportive for self-organization of drug users. Most drug users had homes, police were harsh, but there was no scapegoating or no extreme scapegoating of drug users. Methadone maintenance provided addicted users with new options for spending their time, including organizing protests against old policies and programs which were considered harmful. Drug users who started to organize also found allies, including church groups who gave them places to meet and other resources. Junkie Bond operated primarily through peer networks, often well integrated and engaged with drug supply networks, and provided a whole array of mutual aid functions, including advocacy with drug treatment providers, peer education, needle and syringe programs, legal advocacy, and consumer advocacy with local drug suppliers. Second, so this first period, I call it the grassroots period, and after 2000 until 2016, I guess we could say that harm reduction comes of age. And why 2016? Because harm reduction was recognized by UNGAS in 2016. To exemplify this stage, I chose the campaign Support Don't Punish. Support Don't Punish is a global grassroots-centered initiative in support of harm reduction and drug policies that prioritize public health and human rights. The campaign seeks to put harm reduction on the political agenda by strengthening the mobilization capacity of communities targeted by the war on drugs and their allies, opening dialogue with policymakers, and raising awareness among the media and public. Every year, an increasing number of activists in dozens of cities all over the world join this unique show of force for reform and harm reduction. This campaign highlights some key messages. Drug control system is broken and needs reform. People who use drugs shouldn't be criminalized. People involved in drug trade should not face harsh or disproportionate punishments. Death penalty should never be imposed for drug offenses. Drug policy should focus on health, well-being, and harm reduction. And the budgets need rebalancing to ensure health and harm reduction-based responses are adequately financed. My last example concerns human rights in the center. The Convention for the Elimination of All Forms of Discrimination Against Women sets the standard since 1979 of human rights regarding women and girls. It can be described as the International Declaration of Women's Human Rights. Portugal presented country developments last year, and we presented a shadow report entitled Issues Affecting Women Who Use Drugs in Portugal. This report describes some of the problems and inequalities faced by women who use drugs in Portugal, elaborating on priority issues, evidence, and recommendations. Includes information on institutionalized discrimination and violations of the rights of women who use drugs, including those associated with gender-based violence, access to health care, parental custody rights, and disproportionate sentencing. Recommendations to the Portuguese authorities. Portuguese government still does not have adequate resources for women-specific harm reduction services, which amounts to discriminating against women who use drugs in accessing health services, adjust existing harm reduction and other HIV prevention programs to allow for greater uptake by women who use drugs by hiring female staff, providing on-site child care support, women-specific information, education and communication resources, flexible service hours, and expanding health in care fixed sites to include mobile outreach services, and finally ensure meaningful involvement of women who use drugs in the design, implementation, and evaluation of services. I finish with one message: sisters, brothers, own your space and own your role.
Thank you a lot, Lydia, for this overview and for stressing the fundamental role of people who use drug in fighting for their rights. Thank you so much. And now we change our context and we go to Lebanon. And so I give the floor with Michelle Wazan, who is with us virtually online. Michelle works with SCOON, that is a Lebanese treatment and harm reduction center, and she is the director of the drug department of this organization. Michelle, up to you.
Thank you so much, Susanna, for the introduction, and thank you for having me. I just want to make sure that everybody can hear me.
Yeah, we can.
Can you also see the presentation? Is my screen being shared?
Yeah, we can see it, yeah, Michelle.
Great. Okay, so just to, so thank you everybody for your interventions. I'm going to be talking today about the right to health in Lebanon. So it's actually quite challenging to reconcile the right to health and sometimes even the right to life of people who use drugs in a system that criminalizes them. In Lebanon, drug use is punished by law, and it carries with it a prison sentence of 3 months to 3 years and a hefty fine. While the law punishes the use of drugs, it also acknowledges that substance use disorders and drug use are matters of public health. As such, it establishes the principle of treatment as an alternative to prosecution, which effectively creates a diversion mechanism from the judicial system to the healthcare system, where people arrested and charged with drug use are allowed to resort to treatment instead of being sentenced by a court of law. One way to look at this system is to consider it mandatory treatment, whereby the alternative to treatment is punishment and prosecution. For its time, however, in 1998, the law was considered to be progressive, as the efforts of civil society made it so that at least legislators acknowledged the public health aspect of drug use and the right to health of people who use drugs, providing an alternative to pure criminalization. The Lebanese law on drugs is still one of the most progressive law in our regions. In order to do so, the law established the Drug Addiction Committee, which acts as a link between the judiciary and treatment centers and oversees the treatment programs until the time they are completed, allowing for the judiciary to drop the charges against the person, keeping their criminal record free of drug offenses. Another way to look at this system, which we choose to do, is to consider that for people who use drugs that do not need treatment, it's a way to be introduced to health and harm reduction services free of charge, to know that there is a place that can support them if they ever need it, and more importantly, keep their criminal record free of drug offenses. SCOON, where I work, is one of the outpatient harm reduction centers to which people can be referred for treatment by the judiciary. Now that we're somewhat reconciled with this idea of treatment as an alternative to prosecution, looking at the practice and the implementation of this right to health frames the need to decriminalize the use of drugs in Lebanon. Since the passing of the law in 1998, only a little more than 2,000 individuals have been referred to treatment from the judiciary. This remains very low in comparison to the 3,000 individuals who are arrested yearly for drug use, and another 6,000 that are interrogated for the same charge. This means that only 1 to 4% of people charged with drug use have had their right to treatment and to health respected and implemented. The reasons for this are multiple. First of all, the Drug Addiction Committee wasn't activated until 2013. And until then, judges were unable to refer people to health services due to the shortcomings of the state in creating the very mechanism it had set by law. Other reasons have to do with the centralization of the Drug Addiction Committee and of the majority of treatment centers in the capital. Finally, the knowledge and attitudes of judges also plays a role in that. According to a survey we conducted in 2018, a significant portion of them did not know that the Drug Addiction Committee had been activated, whereas another percentage of judges did not believe that people who use drugs should not be punished. Criminalization and prejudice also play a role beyond arrests for drug use. One of the main challenges we also face in Lebanon is preserving the right to life and the right to health of people who use drugs in cases of overdoses and drug-related emergencies. Most people going through overdoses or their friends find themselves reluctant to seek emergency medical care for fear of being arrested, which leads to people dying home alone or being thrown in front of hospitals with no relevant indication and information for the medical staff to appropriately respond. These fears are not unfounded. Although the practice is not legal, most hospitals in Lebanon report overdose cases to the police upon receiving them. Knowing that overdoses are preventable and that every second counts, hospitals, both private and public, hinder fast and safe access to emergency medical care by reporting these cases to the police. To respond to this issue, and as a result of SCOON's advocacy with the Ministry of Public Health, the ministry issued executive circulars that explain to hospitals that they should not call the police in cases of overdoses. Despite these circulars, only 27 out of 107 hospitals can be considered safe hospitals for people who use drugs. We conduct a mapping of safe hospitals every couple of years, and every time we do so, we are reminded that this is what criminalization does. It's not just law, it's not just text. It also becomes social, and this is where it gets dangerous. Criminalization should never get in the way of harm reduction. The obstacles to achieving the right to health as provided for in the law on drugs and with regards to hospital access underline the necessity to decriminalize drug use, but also betrays the lack of investment of the state in the health of people who use drugs in Lebanon. Today, in the midst of the compounded crisis Lebanon has been battling with since 2019, the devaluation of the Lebanese pound and the lack of basic services, one of the first victims of penury and instability has been people who are on opiate agonist treatment. When the time came for the state to list essential medications, those that needed to continue being provided and for which the state has to allow lines of credit, opiate agonist medication did not make the cut. In Lebanon, we're talking about 2,000 or 2,500 individuals who take this medication. It's not a huge number, but it's 2,500 people who have worked very hard to regain their lives in some form of stability. Today, all of it is at risk, again, because of the lack of investment of the state in the right to health of people who use drugs. Ironically, investment in law enforcement, specifically the repression of people who use drugs, has not ceased. Years of criminalization have mainly caused harm. Criminalization has hindered investment in health and harm reduction services, which have only so far been the responsibility of NGOs. It also challenges access to safe and reliable information, safe access to medical services, access and availability of medication, and also leads to further marginalization of certain groups of people who use drugs, such as refugees, sex workers, and LGBTQI individuals. Thank you.
Thank you, Michelle. Thank you so much. And now the conclusion, the last contribution by Marco Perduca. Marco, welcome. And we asked Marco to create a connection between the right to health and the right to science and to research. Marco, please.
Thank you. Good morning. Can you hear me?
Yeah.
Okay. I'm not in a prison cell as it looks, but I'm in Gdansk, Poland, where this afternoon we will speak about among other things, two European initiatives, one on cannabis and one on psychedelics. And so if you're interested, eumonths.eu is the website to browse. The sister to the right to health is in fact the right to science. It's not known with this name, right to science, but the three main elements of the right to science can be found in Article 15 of the International Covenant on Economic, Social, and Cultural Rights. And in particular, they revolve around freedom of research, regardless of the topic researched and the place where it is researched. Of course, there are some economic consideration to be taken when we talk about least developed or developing countries. So if they don't establish, let's say, a mega multi-research center, it's not a violation of the right to research. But certainly, if we move to the second element of the right to science, they should have access to the knowledge produced by research. So the second element of the right to science is sharing the knowledge produced by research. The third, and it's the last and most important to what we're discussing today, element of the right to science is the right to enjoy scientific progress and most of all its applications. And what we have heard since this morning, it's a very patent, widespread and systematic, if I can use the terminology of international humanitarian law when it comes to crimes against humanity, violation of this part of Article 15 of the International Covenant on Economic, Social, and Cultural Rights. When every time we hear the expression evidence-based, we in fact are confronted with the need to use that evidence, not because science is a new religion or is an ideology to which we have to obey to, but because this wealth of scientific literature has been produced by people distributed around the globe that have peer-reviewed their studies, and they have criticized each other fiercely sometimes and have arrived at some sort of a consensus conclusion based on facts, not on ideology or not on approaches. And this is it should have always been the way in which Article 15 should have been read by member states and governments, but it has been further clarified in 2020 by a general comment, number 25, on the so-called right to science by the same committee that Adrian presented at the very beginning. It is a 20-page document that can be found online. It's very important because it clarifies a lot of issues related to the ways in which not only countries should establish a national plan for science, but also what it is meant to open up people participation in producing science. What we have heard before about the Rotterdam example, for instance, is an example carried out by non-scientists that has produced some scientific evidence, and their use has made a crucial difference between the policies applied or the behaviors applied in a city that were not being applied in a city nearby. Another important issue to take into consideration is also so-called self-medication. People are experimenting on themselves. One could say that the beginning of harm reduction could also be considered some sort of self-medication. And this is an alternative to what science or institutions have been promoting or imposing, but is something that the committee says should be taken into consideration. Last, but certainly not least, statistics are also an important part of evidence-based. We have, in studies in general, we have seen the INCB report coming out last week where they criticize legalization of cannabis without any substantial element coming from studies carried out. So this is very important. I will leave you also renovating because I know it's late, renovating the invitation for civil society and individuals to contribute to the process launched October last year by the Committee on Economic, Social and Cultural Rights. This general comment, which is a crucial document, will arrive a couple of years before, if there is going to be a 10 Nangas plus 10 where member states should discuss drugs, but it will help what we've been calling for many, many years and the UN has never done, for an assessment of the impact on economic, social, and cultural rights. It would have been ideal to have a joint general comment, because we've heard that penalization is stigma and has a big impact on what we're talking about today, but apparently for some bureaucratic reasons it was not possible. But we have to be very proactive, because we know that the composition of the committee is not, again, ideal, and there are countries that are already trying to block the whole system. I thank you for the opportunity. Enjoy the rest of the stay.
Thank you, Marco, so much also for this last invitation. Our time is up, I'm afraid. And so I want to thank all the speakers. And we, in this side event, we try to focus on some critical key points dealing with the right to health. And also we try to find some possibility of changing things and going forward. Thank you so much. Bye.
Ciao.